This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you, John. Thanks for the opportunity to talk about our little small area of the world, a rapidly changing one, and I related a lot to the last presenters, to Sharon and Brittany, what they're talking about in relation to having segregated areas within their own hospitals. And I think a little bit of our small story may relate to some of the issues that we've dealt with that. So I would also like to apologise for, not apologise, but say my co-person in crime, Dr. Campbell, was going to be here with us, but there was an issue of either here or an overseas holiday, which was already booked. So she's having a Mai Tai on the beach somewhere at the moment. You've got to go the right way with this. Okay. The background, we've all seen this before. We've seen the majority of this stuff before. That we have been forced or formed or required to start looking at the recognition and management, especially through our national standards. I think Standard 9 is going to put me in the grave. Evidence supporting the benefit of these things is one of the difficulties. How do we know that those systems are actually working? They're confounded. We can't say this, we've done better because they're confounded. So many other things we're improving within our hospitals. We have poorly reflected endpoints, so traditional endpoints to say, are we doing well with this or not? And probably one of our major failures is the failure or the afferent arm or failure to actually implement that call. That is where our stumbling block is. We found that. So the main aim, of course, is to optimise our resource utilisation in our economic climate through our health systems, protect our inexperienced staff. Brittany was talking about our interns, and they're the ones who copped the brunt of this in the immediate aftermath, and also minimise the underskilling of our staff. Okay, geography for us, it's Nambour Hospital. No? Nambour Hospital's on the Sunshine Coast. We have a health service that has 4 campuses, soon to be 5, and Nambour Hospital is the receiving hospital for all those sicker patients, so we tend to get them at 24 hours a day into hospital transfers. In 2009 we had a MET system introduced, and that was with our traditional markers, cardiovascular, respiratory, neurology, but they were very difficult to get done. Okay. Activations, very small. In a hospital we're now between 360 and 400 depending on what figures we take, and we're soon to move into a much larger one. Okay. February 2012, it was already been mentioned that the state-directed ADS forms were introduced. These ADS forms, as you've seen before, they're combined track and trigger aggregate scoring. These were brought in from state level with probably a suboptimal education process that was directed out from outside of our own hospital. So we had some experience from other centres, especially down in Adelaide, where these systems had already been introduced, and we expected to have a rapid increase in numbers. And we thought, here we go, everyone get a bike, we're going to be running. Didn't happen. And we looked back and said, why? We only got 20 calls a month. What's happening? And this is a typical failure to initiate. As you see, the blood pressure is in the purple area, which is an emergency call. It didn't happen. So we thought to ourselves, what is going on? Why is this happening? What can we do? Then we had, I think, an unfortunate incident, but it helped our hospital. This is a staff member, well known to us, known to surgeons, anaesthetists, and she had a routine operation. She went home, she came back in again, and all the things that could go wrong went wrong. She deteriorated after hours on a weekend while there was emergency surgeries happening, and there was junior nursing staff on the ward. The surgeon was called, but who was a friend of hers. He was actually in theatre. I'll come and see you after. The registrar went home sick. I think he had a bad curry the night before. We had very minimal other staff on. The nursing staff weren't game to actually go in to see this lady very much because I think they were afraid of who she was and what she was. A whole lot of things happened, and this lady deteriorated to the point where her husband walked into the theatre department to find an anaesthetist. This really, and to say it doesn't happen or can't happen, it shouldn't happen. Now, we had a big shake-up with this. Precipitation to change. So we had a solution. What can we do? A two-tiered response system. A smaller response team to look after the deteriorating patients. A larger traditional response team for our code blues. Okay? One of the biggest things we brought in which made a big difference to us is the mandatory calling. Irrespective of medical presence, if the patient meets the criteria, it is done. A couple of things is good for this. If we have a junior staff member there and they feel they can handle it, but our nursing staff are really worried and there's no improvement, we call it. It's fantastic for capturing your data as well, so you capture it regardless of whether you needed a full team. But it was also seen as a really good thing for education of our junior medical staff. You got them there. Rapid de-escalation. The home team resumed the care as soon as possible with some education. This left the management of that patient to the home team, not to an outside team. A lot of the issues that we had when we proposed these, we had a lot of focus groups and we said, why aren't you calling? The nursing staff said, look, they don't seem that sick. And we have to call this for this track and trigger. Said we have to call them. But, you know, I'm a good nurse. Why should I, you know, I'm going to be seen as being an idiot if I call this. Loss of acumen. Okay. So we had to overcome that. So a smaller team of 3 people who walk into the area for a deteriorating patient is a lot less confronting to our nursing staff, so they're more likely to actually call. Another thing was that they were fully supported by our management. Our nursing staff were afraid of being abused by medical staff for, why did you call this? I'm busy, I've got 4 IVs to do, there's someone else. We actually had 2 or 3 code of conduct issues from medical staff who did that. The nursing staff and medical staff were protected and encouraged to do this from executive level down. Since that, the culture has changed and it's really, really well accepted and it works very well. Our barriers, executive resistance. We said if we're going to do this, we need some more money. I won't go into that any further. Nursing resistance, fear of retribution, question acumen, as I said. Responder resistance, frustration, I've got to leave my patients and go do something else. Who's going to look after those? The home team resistance of loss and control, and they felt that might be some punitive stuff there. Okay, and of course our resistance to change. These are the things that we had to do, and we felt we did that. We had a lot of focus groups, and we spoke both with nursing and with the medical staff, right through from the senior consultants to get them on board. Okay, keys, governance, multidiscipline committee representation. Our resuscitation committee, or our MEAC committee, has both executive, senior anaesthetic, nursing, paediatric, obstetric, all on that, nursing staff as well, and nursing staff from the wards, and all the people on that who can go on that team. We have about a 15 or 20 member group, which is great. Global ownership, everyone wore this. Every area, both nursing and medicine. Okay, and our education programs, which was touched on a little bit earlier, they are really our key. When you hit that place, orientation is sometimes a hit and miss affair. We found medicine, you may be in the hospital for 6 months before you actually got an orientation program because you hit the floor running. That no longer happens. Okay. We also, blessed in our area, have a nursing education group that works very well together. So nursing educators, clinical coaches, and we developed unit-based support champions. Every single unit has someone who knows the system, why it works, how it works, and can actually educate and support the new staff with that. Outcomes. We looked at medical emergency call numbers. That's the traditional method of looking at it. And we also did an evaluation of Met system, an effect on ICU patient outcomes, which we thought were a little bit more specific because our original traditional endpoints can be blurred with other things. As we can see, before the introduction or the rollout of the ANZICS system, there we had very few calls. Then we had a period of 4 or 5 months where nothing happened and we expected it. We started the education. As you can see, we have climbed rapidly. In this period also, we've had a large increase in throughput through our hospital. We're moving towards a 600-bed hospital next year, and so other services have come online, so our outpatient requirements have really increased. But as you can see across the bottom, even with increased numbers from 30 to 40,000 extra per year, we haven't had any real increase in arrests and deaths, okay, which has really been a benefit to us. Whoops. When we looked at the ICU-specific endpoints, what we thought we would look at were these: a reduction in the severity of illness scores, the Apache 2, 3 and the SAPS, at time of admission, which, as we know, is a universal methodology, a reduced requirement for initiation of organ support. So we thought if we get them earlier, even though they have to come to ICU, we might not have to do this for much more. A reduced ICU length of stay, a reduced ICU mortality. Okay? We did also continue to record and look at our traditional outcomes of MET calls, hospital mortality, cardiac arrests as such. So what actually happened? We lose our methods, single centre study. We looked at 18 months prior to the introduction of this system and an 18-month period after to give us a reasonable database. Our cohorts, as you'll see from there, it was a reasonable number into ICU, and the majority of the average age hadn't changed, 64 to 64.1 to 64.3 in the two areas, and also the number of medical patients is quite high, which is predictable. Okay. Results. Overall mortality decreased, but short of significance, unfortunately. There was no statistical change in the number of unplanned admissions. That surprised us. True cardiac respiratory arrests went from 1 in 1,000 to 0.7, and again, that is not statistically relevant, but one of our ICU consultants is quite happy to say that's a 30% drop, so he's really happy. ICU-specific endpoints, severity of illness scores. As we can see here, both the Apache 2, 3 and the SAPS, we had a decrease in those. Okay. Proportion of patients with high severity of illness scores, marked decrease. Okay, and this is what we predicted would happen. And we think, oh, we're getting soft admissions into our ward, into the ICU. We're getting them early. They're not as sick. Okay, we're sort of wasting our ICU resources. Median length of stay, quite significant. We dropped it a full day, and they were quite significant over that period of time. And you know how much it costs to have someone in ICU for a day. Okay. Initiation of organ support, unchanged. And we thought, oh, are we putting soft admissions in? We weren't. The people still required intubation, ventilation, inotropic support and dialysis. So we were initiating those on roughly the same numbers. There was no great difference in the two periods, which said to us they are still sick. ICU mortality, unchanged after ICU admissions from the ward, very little. However, again, our director of ICU said, look, our ICU mortality is very low anyway. However, it still didn't meet statistical requirements to say, yes, we've made a difference. So what, in summary, because I know I've put a 25-minute into a 15-minute here. Efficient rollout, rapid progression to a mature system. Statistically significant reduction in the severity of illness, the percentage of patients scoring very high severity of illness scores, no reduction in initiation of organ support. And that was, to us, was telling. statistically significant reduction in ICU length of stay of 1 day and a 30% reduction in number of patients spending more than 7 days in ICU. We are only a small ICU unit at this point. We're about to move into a 40-bed ICU. Okay, so we need to get a system where we can have good predictors before we move into this system, into this new hospital. Anyone want a job, by the way? Okay. Impact, improved patient outcomes, positive effect on morbidity, cost savings with the decrease, which also made executive very happy. We saved on our small number of pages $129,000 per annum, which we said, well, isn't that wonderful? Now we can actually employ someone to do some of this running, but unfortunately the costs were absorbed. Where to from here? Refinement of ever-increasing met calls, and hopefully this is what I'm going to get from you guys. I know I'm being told to finish up. Last little point. Since we brought this system in, we have not had one SAC1 event from an undetected deteriorating patient. Now that is something we're very proud of, and we have a very robust system of looking and trying to capture if we're failing. So, and I didn't realise that until the state told us. Okay, which is good. Where to from here? One of our biggest issues is with the calls. Hypertension. 46% of our calls are for hypertension. As you can see there, the symptomatic in red. Whoops. Symptomatic in red is very small. Our problem, asymptomatic hypotensive calls. So we need to look at that trigger system. It's a statewide trigger system, and we have the opportunity to do that in the upcoming months. And hopefully we can reduce our number of calls by difficult. There's a lot of people are trying to work how we can actually do this. When is low blood pressure, without missing our trigger points and getting them seen. So we have to balance that. Okay. I hope that you guys can help us out. Thank you.